do it 50-50. So one day you do a 6, the next day you do a 12 or something like that. But they have to be really large to do that. So a normal size patient, you would do a 6 MV. And dose. Did anybody get to what the dose would be likely to be? Anybody? What kind of dose are we looking at? For the chest wall or the breast?
4,500 to 5,000 centigrade.
That's possibly, I would add another 500 onto that. So about anything from 45 to 5,500. So that would be the dose for the tangents. So supraclavicular, let's go through and do it again here. Supraclavicular field, so what indication would we need to have to include a supraclavicular fossa field? What do I mean by a supraclavicular fossa or supraclavicular field? Yeah, so it's up here somewhere, right? So why would I include that? Why would I treat that?
If there's nodes up there?
Yeah, if there's nodes up there. When we're treating the breast, we would be treating part of the axilla anyway. So to do the supraclavicular field, we would be treating this area, which includes the supraclavicular nodes, the infraclavicular nodes, and some of the axillary nodes that we didn't get to with the tangent fields. So the borders. Basically, you want to match the border. So you take the superior border of the tangent field and you use that as the inferior border of the supraclavicular field. And then the supraclavicular field goes up to the top of the shoulder. So you have a little bit of what they call flash again over the top of the shoulder. Medial, you would go to midline again here. And in this case, you certainly would have the patient's head turned that way. So you're not treating the throat. And lateral would be including the head of the humerus. And beam arrangement, usually just an AP field for the moment. There's another one later on. Beam arrangement, okay. So what about shielding on this one? You're treating here.
Isn't there a brachial plexus or something?
Brachial plexus is further down here,
Down.
so you don't want to worry about that. Some physicians will shield the neck. So they'll put a shielding just on the border of the outside border of the field here. Anything else you can think of? I mentioned that we're including the head of humerus. And I'm including the head of humerus because that also makes it clear that we're treating the axilla, which sits underneath the head of humerus. Remember, the head of humerus is up like this, right? But a lot of physicians will shield the actual bone. They'll make sure that it doesn't shield the axilla, but they'll actually shield the head of the humerus itself. Does that make sense? It may sound weird that we're including it, but we're shielding it. But that's to make sure that we've got enough on the area. So that's really all the blocking we need. And energy? 6 MV, same. And a dose. Again, this time you're a little more correct. It's usually about 4,500 to 5,000 for the supraclavicular field. Okay. Okay, PAB. What the heck is a PAB? Anybody care to guess?
Posterior something.
Mm-hmm.
Oh, posterior anterior border.
Good guess, but no. It's called the posterior axillary boost. The idea is that in some patients, if you're just giving one field to the supraclavicular fossa, the axilla may not get as much dose as it's needed. So they put on this posterior axillary boost, commonly known as a PAB, in order to boost the dose at the center to the dose that we need it to be, which is usually about 45 to 5,000 centigrade. And that would be a 10 by 10 field approximately, right here, sort of here. So that you're treating the axilla. So the beam arrangement is just a posterior axilla. And I've told you the indications, so we're okay on that. Borders, depending on what area needed to be boosted, it's usually just over the axilla. There's usually no shielding. The energy is usually the same, 6 MV, and the dose is enough so that it boosts the supraclavicular to the correct dose. It's usually around 1,800 to 2,000 centigrade. Very few people do a PAB anymore, but you have to know what it means. Okay, IMC. What was the IMC again? Internal mammary chain, or yeah. So this is the nodes that run along each side of the sternum. We very, very rarely use this anymore. I don't think anybody is doing it anymore, but we'll go over it anyway. The indications would be that we have affected nodes in the IMC that are not going to be covered by the medial border. There are two ways to do this. You can enlarge the medial. You could spread this out a bit so that you're including the ipsilateral side of the IMC, or you could do a field which runs down the middle. So you've got nodes here and nodes here. The last time I saw something like that done was in the early 1970s. They very, very rarely use it anymore, but since they put it in the book, we better cover it. So the beam arrangement is a field straight down the middle of the sternum. And it's usually an 8 wide by about a 15 long. So just enough to cover the sternum. No blocking, usually. Energy, if we did do it, would be a 6 MV maximum. And the dose would be about 4,500. But I doubt very much whether you'll ever see that done. And the boost. Okay. So, a boost. Why would we need to do a boost? And if we do need a boost, how would we do it? So we've done our 5,500 to the tangents. We're not doing a supraclavicular field, we're not doing a PAB, we're not doing anything else, we're just doing tangents. And the patient has had a lumpectomy. What would we do? First of all, why would we do a boost? And how would we do it?
Isn't that where you're treating the tumor bed, the area around the tumor and the tumor itself, just that area instead of the entire breast?
Yeah, but that's not what we're talking about at the moment. You're talking about not treating the whole breast, just treating the tumor bed.
Right.
No. This is what we're talking about is after we've completely treated
Right,
the
that's what
whole
I was
breast.
I thought they did that after, like you did that first and then you did it again on just that area. No?
What we would do is we would treat the scar of the lumpectomy or the segmental mastectomy or whatever it happens to be called. We treat the scar. Why would we treat the scar? Why would we give the scar an extra oomph of treatment? Anybody? So when they're doing the surgery, the surgeon goes in with his scalpel and he takes out the bad stuff, the lump. And then when he takes the stuff out and all the surrounding tissue that he needs to take out, then they sew it back together again and that gives you the scar, right? So far so good. Why would we necessarily need to treat the scar?
Healing, maybe?
Pardon?
Healing? Help with
Healing? No, hopefully the scar is healed. We don't treat anything that is not healed, so the scar has to be healed before we start any treatment. So if the surgeon has got microscopic cancer cells that obviously you can't see because they're microscopic, where are they going to land if the surgeon's taking out his scalpel out of the tumor area, coming out over the skin, and then they stitch it together and that leaves a scar? Where are any microscopic cells gonna stay?
Suture site.
Yeah, the scar. They're gonna be, anything that's left on the knife, anything that's left on the scalpel, when it comes out, will seed, what they call seed, onto the scar site. So to be sure we treat that scar, we give it a boost. Because 99 times out of 100, if you have a recurrence, it's over the scar. So we treat that scar area. So how do we do that? What kind of treatment do we use? Or what kind of treatment can we use?
If it's just on the scar, could we use electrons for that?
We can. Now, normally what they would look at would be how deep the lumpectomy was. So if it was relatively close to the skin, then you'd want to treat that as well as the scar. And we could quite happily use electrons in that case. If it was rather deep and you want to give a boost to the whole area of the lumpectomy, then we may use photons for the boost. So, if we're treating with electrons, what kind of beam arrangement and borders may we use? So the borders would be the scar. We'd have, usually, if the scar is, over here, sorry. Let's say the scar is here. There's your scar. So to treat that scar, we'd go about a centimeter above it, centimeter on the side, centimeter below it, and join it. That's how we would treat that area. So that's the area that we would treat. That's the borders. What kind of beam arrangement might we use if we're treating with electrons? How many fields do we normally use with electrons? One. We'd only have one field. And we would treat it, what was the word of the day on Wednesday? En face, yes. So we would treat it en face. And the dose, we probably wouldn't have any shielding. What we would do for blocking, we would make a cutout, an electron cutout of the actual area. So all we would be treating would be that size of field, because remember, you have just squares for the electron cones. You have a 6 by 6, a 10 by 10, a 15 by 15, a 20 by 20, and a 25 by 25. So even if that's a 10 by 10, you're doing, we'll say that's a 10 long, which is fine, but that's maybe only a 4 centimeter wide. So you'd have to do a cutout to match that field. And we'll go over that later, much later. And energy. What energy might we use? With most energies, most electron energies, most machines would have various energies of electrons. We'd have a 6, a 9, 12, a 15, an 18, a 21, MV electrons. And depending on how deep you want to go, it depends on how high the beam energy is. Normally with electron boosts, you would use something like a 9 MeV, or a 12 MeV, depending on how deep the doctor wants to give. Any questions on that? Okay. And if you go back in your books to electrons, which is, let me see, you remember these rules of thumb that we talked about? I'll get these later for you. So that's all very well if they want to do an electron field. If it's too deep for electrons, they may want to do a photon field, a photon boost. In that case, what we could do is just smaller tangent fields. So if we put it here, for example, we could do a little tangent field this way so that we go deeper. So it really does depend on how deep the lesion is, what energy we use, and what type of radiation we use, either photons or electrons. And the dose can be anything from 1,000 centigrade to about 1,500, just to that area alone.
So for a photon boost, you would use the same energy that you did the original tangent field with, just in a smaller area?
Same dose.
Like if you, like that one, whatever energy level you did in the tangent field.
Yeah, you would use, if you use the 6 MV, then you'd use a 6 MV usually.
Okay.
For a boost, you wouldn't use anything other than the 6 MV photons.
Okay.
If you're using photons, you wouldn't use anything other than the 6, put it that way, because they're much smaller. Okay, so side effects. So we have skin changes. Erythema. What is erythema?
Reddening of the skin.
Reddening
of the skin.
Reddening of the skin, yeah. What is dry desquamation?
Dry.
It's the flaking off of skin.
Yeah, peeling off of the skin, but dry. What is moist desquamation?
Same thing.
Moist desquamation.
It's more like moist peeling and.
Yeah, that's right. The chances of you seeing a moist desquamation with our treatment at the moment is fairly rare. But occasionally it happens, depending on the patient's type of skin and depending on how well she follows the directions that she's given. Fatigue. All patients in radiation therapy tend to get fatigue. That's just one of these things. And we suggest to them that they have an afternoon nap. Just like the kids, go and have an afternoon nap. It's not a sort of fall asleep at the wheel type tired, it's, you're just feeling tired. Pulmonary effects, just like we were saying, only this is a late effect. So is lymphedema. Lymphedema usually occurs following surgery, not necessarily radiation therapy. But the pulmonary effects can be ours, unfortunately, the lymphedema, we're not making it any better because we're blasting what remains of the lymphatic system in that area with radiation, which is not making the lymphedema any better. Okay, so brachytherapy, interstitial. We have, oh. We have, needles that go into the breast itself that can actually treat that area with brachytherapy. The other one is a mammocyte. Has anybody heard of a mammocyte? Okay. Let me see if I've got a, I don't think I have, but let me see. No, I don't have it. Okay. A mammocyte is a brachytherapy area which okay, a mammocyte is a treatment which is given using a high dose brachytherapy, an HDR machine. And what happens is that the surgeon will go in, they'll take the lumpectomy, they'll do a lumpectomy, and either in surgery, either in the OR or in the physician's office a couple of days later, they will insert a little balloon. And the balloon comes, they'll bring the balloon, they'll put the balloon into the hole which has been made by the lumpectomy. And the balloon end will come out of the patient's skin about here somewhere. Then they come, yeah.
What if you have like a patient that has like breast implants? Like would they have to get that removed before any treatment?
No, we can treat through breast implants.
What about like the needle going in?
Or the needles growing in, we probably wouldn't do that, no.
Oh, okay.
We probably would not do any brachytherapy on a patient with breast implants. But a normal external beam radiation therapy treatment, I've treated dozens of them. There's no problem with them. So the lumpectomy, the patient comes in, it's usually a Friday, and we do a CT scan, and we inflate the balloon by attaching normal saline and pumping it in through the whole exit here that has the tube. And then that, on a Monday morning, will attach to the HDR machine, and the radioactive source will be pushed from the HDR machine into the mammocyte balloon. Patient will be treated, withdraw the radiation, send the patient home. And that is done 5 days a week, twice a day for a week. So that's 10 treatments, 5 days a week. And that's the patient finished. But that is a very strict protocol, and only certain patients are allowed to have that done. They must only have a lumpectomy, nothing else. And I'll find you a video of the mama site and send it to you with the videos. Okay. So I just wanted to show you something before we finish. Which one was it? It was this one. I just wanted to show you the pictures of the, this is an old one. There's an inflammatory breast cancer. I think that's the image that I borrowed to show you the so inflammatory breast cancer looks red, feels warm, thickening of the skin, and it is usually primary care physician think it's just an infection. So let me, I'm just trying to find something that I saw here, and just bear with me here. Right, well, I'll send you this as well, because it gives you a lot more information on BRCA1. Come on. Early detection, surgery. Okay, so here's mammogram here. So here's one. You can just see it here. Here's another one. And the other one is over there with the this is an ultrasound. So you can see this looks nice and circular, so there's nothing wrong about that. That's just cysts. So I'm just going through this quickly because there's, oh, here's an MRI. You can see the lesion very, very well there. This isn't somebody who has very dense breasts. So biopsies. Oh, come on, people. Okay. Perceptin. Okay, so this is what I wanted to show you. Okay, so there's a lumpectomy. So you can see the scar here. Tiny little scar. And after that, we would treat the whole breast. This is a simple mastectomy. Basically, all you do is take the breast off and you're left with the small, relatively small scar. This next one is a modified radical in which you would take the breast and the axillary nodes out here. And the next one is what we used to call the radical. And you can see, it's a very old photograph, but you can see why it's ugly and it looks evil. So the scar reached right in, and it actually came from basically down the arm here, up through the breast or the axilla, and all the way down to here. These little nodules are skin nodules from the cancer. And this lady is left with basically skin and ribs. No musculature left at all. And this was first done by a gentleman called Halsted, and it was called the Halsted radical mastectomy. And they have been doing it exactly the same way since, I think it was 1898. Halsted first did it. And they were still using it in the 1960s. In Europe, they stopped using it. In Britain, they stopped using it about 1965. And Europe, they stopped using it in the 1970s. The US was still using it in the 1980s. So, there you go. And I will send this to